Welcome everyone to today's Pulmonary Grand Rounds. It is my great pleasure today to introduce Dr. Kathleen Akgün. Dr. Akgün is a proud New Jerseyan and also a Guns N' Roses fan. She got her BS from Rutgers and then her medical degree from the University of Medicine and Dentistry in New Jersey, and then a master's in science here at Yale. And it has been our good fortune that she's been with us since internship. So she came to us as an intern. We were really fortunate to recruit her into our fellowship, and now she has stayed on here as faculty all this time. I met her many years ago, and it's been my good fortune to have been one of her early mentors. She's currently clinically based at the VA, and her research is focused on studying veterans with HIV. She has an extensive CV with well over 100 publications. And I think one of the things that she is probably most proud of is her advocacy work. And today you're going to hear a little bit about what she's been doing when she talks to us about equity and patient-centered care for ICU patients experiencing incarceration. So welcome, Kathleen.
Thanks so much, Margaret, for the kind introduction, as well as to the section for the opportunity to speak about this area that has really given me a new boost and energy and enthusiasm for my professional role. I'll also wish everybody a happy Valentine's Day, happy Ash Wednesday, and snow day recovery. We don't handle it too well all the time in Connecticut. How do I best do this? So here is our accreditation slide, your codes that you need to get in for CME credit, and we will launch into the outline. I'll first discuss disparities associated with mass incarceration and explore the impact of aging for people who are incarcerated in this setting. We'll then describe how patient-centered care is threatened for patients who are experiencing incarceration and coming in for acute care. And then I'll introduce Scopes and Shields, a group that I am a co-member with a number of colleagues around the country, to identify and articulate some strategies to better advocate for our patients with regards to use of shackles, protecting privacy, and promoting shared decision-making between identified surrogates and healthcare provider teams. So a few disclaimers as we launch into the discussion. I have at the bottom here, probably the least interesting part is that I'm expressing views that are my own, not that of the US government, nor of any institution or agency or professional society that I'm part of. But more importantly, I want to make it clear that I'm not intending to sound adversarial against police officers, and we have tremendous respect from Scopes and Shields for the work that's done by law enforcement. We also are not advocating for people to disregard rules in place to keep healthcare providers safe during encounters with patients who are also incarcerated, and encourage a sort of group team-based discussion over the appropriate level of restraints that are used for patients, and not intending this to be a sort of top-down attending dictated plan for tearing off restraints for everybody. Because sometimes patients do pose a risk for patients, sometimes patients do pose a risk for staff who are at the bedside, and we might not necessarily be privy to all the risks that maybe our respiratory therapists and nurses and other members of the team are facing while trying to provide care to the patients. But other times, maybe we're defaulting to something that isn't necessarily written or understood, and we're not asking some questions that could encourage us to advocate for our patients in real time. And so further, I want to challenge us to reconsider how we reference this group of patients, and remember that words matter. I ask us to refrain from using words like prisoner and inmates, because this defines patients based on their current criminal status rather than who they are to us, which is patients. This type of language foregrounds the person's worst moments as the thing that we as the healthcare team are most focused on. And this invites stigmatization and judgment, and potentially even less valuation for the life that's in front of us. So we ask you to work towards swiping as best you can from your vocabulary use of words like inmates and prisoner when talking about justice-involved patients. And I'll also acknowledge these points were highlighted by Erin DiMartino, one of our colleagues at Mayo Clinic, who's just always got an incredibly beautiful way with words. So for our discussion, I wanted to introduce a case of a patient who was really physically fit, really proud of what he could do with his body. He was a boxer, but he began to have some night sweats and weight loss. This happened, though, while he was incarcerated. And after some challenges for being able to get his systemic complaints taken seriously, he was finally diagnosed with advanced lymphoma that required hospitalization for treatment to start urgently. This also was co-occurring while he still was incarcerated, and so led to a 5-month hospitalization where he was kept behind locked doors and at times handcuffed to a hospital bed while he was undergoing treatment. And then after having served his sentence, something changed, and he was moved to a regular community-based hospital bed. And he's able to reflect on this and realize how differently he's treated by the very same personnel that were seeing him when he was in the prison ward. And he didn't realize how nicely he could be treated, and likened some of the ways that he was treated when he was on the prison ward as being very much less than and almost like an animal in a cage. So I ask you to think about that, reflect on some of your own experiences in caring for incarcerated patients, and how we potentially are allowing stigma and biases to prevent us from upstanding for our patients. And then I want to start to shift to thinking about why the incarcerated population deserves special attention. And that's squarely located on the very real situation of mass incarceration and health and disparities in the US. For some orientation here, this is a slide also courtesy of Erin that describes the journey for patients through arrest, through ideally reentry. But what we'll be highlighting for today's talk is patients who may be in jail, which notably they may not necessarily be charged with a crime, or those who are in prison. If you're not familiar, the carceral healthcare is unique in the US as the only constitutionally protected group that is guaranteed healthcare. This was something that was established in the Supreme Court ruling of Estelle versus Gamble in 1976 and was felt to be embedded in the avoidance of cruel and unusual punishment in the Eighth Amendment. But what that healthcare looks like is quite variable, and this is a gross oversimplification of what we're discussing here. There are some providers who can provide basic assessments from nursing and physician staff through and APPs through the prison itself and clinics that are available there. But there's also offsite care and specialty clinics, emergency departments, and hospital care, which is what our primary focus will be here. If you're not familiar, the incarceration rates in the US are vastly different from economically similar countries around the world. These graphs here show about 20 countries and their incarceration rates from 1980 to around 2010. And you can see these low-level, sort of almost horizontal lines, somewhere between 50 and 100 rates of incarceration per 100,000 for the majority of cases, except for the US, where we have this very steep 45-degree angle that's perhaps starting to level off a little bit, but is just a completely different animal compared with what the rest of the world is doing for patients. Incarceration varies across the country, and it's not something that is experienced uniformly and can be influenced by what state you live in. So this chart here shows the individual states and incarceration rates for both sort of acute incarceration, so people who are in prisons and jails, as well as those who are under community supervision. And I highlighted Connecticut for us in the orange, which is about the 9th least likely to have people who are justice involved relative to the other states. Though I want to still remember that still puts Connecticut more than twice the rate of what we see for our next sort of competitor, for lack of a better word, in terms of the rate of incarcerating the population that we serve. If you're curious for where people are incarcerated in Connecticut, there are 13 prisons and then some additional detention centers that are scattered throughout, largely concentrated in urban areas, but also I highlight some of the areas that are going to be fed by or served by our health system. So looking at the New London area, looking at New Haven and Bridgeport, and the approximate number incarcerated people who are in those prisons as of September 2023. But we also have to remember that incarceration is not uniformly affecting by geography nor by race and ethnicity. These are estimates from 2023 of people who were born in 2001 and their likelihood for experiencing incarceration among men. And what you see is overall 1 in 10, which is still a pretty staggering statistic to think about, 10% of men. However, among white men, it affects 1 in 20, whereas among Black men, it's 1 in 5. I'll note that this is an improvement compared with people who were born in 1981, where it was 1 in 3, but is still just an incredibly high proportion of people who are facing risk for incarceration. We similarly see disparities in excess representation of Latinx populations in the incarcerated patient group. As I've shown you for the way that Connecticut does or doesn't mirror the rest of the nation, we continue to see these disparities for incarceration by race and ethnicity, as is demonstrated by these rates in the bar charts here. You see the white race represented in the orange and the green representing Black, and you can see that it's nearly 10 times as high for people who identify as Black compared with white. In addition, Hispanics and American Indian and Native Alaskans are also experiencing higher rates. If you're unfamiliar of what the sort of demographics of our state look like, these are estimates from the Prison Policy Initiative, where we see the really gross overrepresentation of individuals identifying as Black, Hispanic, and American Indian or Alaska Native in the carceral system. So not only are these moments of detention going to be disparate, there's also lasting effects on the outcomes and health for patients who are experiencing incarceration. In a survey of patients from the youth survey, they found that 11% of people who identified as Black had at least one incarceration when they were between the ages of 22 and 50, compared with about 2.5 who identified as non-Black. In adjusted models looking for mortality risk for those who were incarcerated, they found no association. But when they started to look by incarceration and Black or non-Black self-reported groups, they saw a substantial and differential impact of being Black and having been incarcerated on mortality during follow-up in these patient populations. That's represented in these Kaplan-Meier curves, with the darker dashed lines, those who were Black and incarcerated, and the green dashed lines who were non-Black and incarcerated. But the hazard ratio also shows a risk of 65% for these individuals. So in addition to the changing demographics and disparities that are seen by race and ethnicity, there's also evolving changes in the makeup of the age groups of people who are incarcerated. And that's demonstrated here with the yellow bar indicating people who are 18 to 24. And encouragingly, you can see that from 1986 to 2016, there's been a steady decline in the proportion of patients who are incarcerated in this age group. However, during that same time period, we're seeing a 4 times to 5 times amount of patients who are age 55 and older and living behind bars. Connecticut is no exception to this and is again following the trends that we're seeing nationally. These disparities that we described for race and ethnicity carry through by age group, which is represented on the y-axis here by about 5-year intervals. And those who are white men's rates for incarceration are represented in yellow, whereas those who are identifying as Black race are represented in orange. And again, just thinking about the sort of toll of incarceration on a disproportionately Black and Brown community, this is something that's experienced throughout the life period that people are followed, and has a number of complicated contributors to it that is beyond the scope of this talk. But I think I've introduced to us that mass incarceration is a uniquely American enterprise. There require a number of initiatives to try to undo that, but again, it's beyond the scope of what I can cover during this 45-minute talk or so. People who are Black and Brown are disproportionately harmed by incarceration compared with people who identify as white, and that we are also seeing an older and older group of patients who are living a lot of their time behind bars. So what does that mean? And I mean, have we thought about what this looks like and how we maintain sort of pulmonary health and all of these things for patients who are living while behind bars? Turns out a number of epidemiologists and health policy experts have been recognizing this, almost silver tsunami among the incarcerated population. And what's represented in this graph is the percent growth of people who are incarcerated and age 55 and older over the 1990 to 2008 period. They're represented by the dark line that just is skyrocketing up in terms of growth of the population over this time period. That's in contrast to the total prison population, which is in the dotted lines, and the general US population of age 55 and older in the dashed lines. What this translates to is over 150,000 people who are older, which for these purposes are 55 and older. And it's projected that by 2030, a third of all people in federal prisons are going to be age 55 or greater. These folks who are aging while incarcerated are developing multiple chronic conditions at an earlier stage and with faster progression than community-based folks. And there's been a fair amount of attention on cognitive impairments and dementia, with certain risk factors related to traumatic brain injury history, low educational attainment, and substance misuse history as contributors to dementia for these folks. In fact, if you read the New York Times, there was an opinion by Katie Engelhardt, a sort of expose about aging behind bars with dementia, and this very interesting sort of caretaking role that many of the incarcerated people are serving for each other when someone's behind bars and having profound dementia and not even necessarily recalling the crime that they are charged with committing and serving out a sentence for. But there's more than cognitive impairment, of course, to growing older. This is an estimate of chronic conditions such as kidney disease, heart disease, cancer, diabetes for patients who are aging while incarcerated. Some of these data are imprecise for prevalence because this is really requiring people to be able to be released and complete surveys, and for us to be able to then get an estimate of what the prevalence of these conditions are. But with that kind of model in place, we are getting a better, clearer picture on what kind of toll incarceration has on health outcomes for patients. And this group looked at people who completed the health and retirement study between 2012 and 2014, and looked at some geriatric syndromes, which are represented on the y-axis, and the proportion of patients who identified as having those impairments on the x-axis. We see 3 bars for each geriatric condition, whereas the lightest green is indicating somebody who had no incarceration. The medium green is those with at least a month, and those who are in the darker green a month or longer. And what you can see is a sort of dose response for certain conditions, like just sort of global performance of ADLs and IADLs and sort of perceived physical health that seems to carry with it greater intensity for those who have had longer time in detention. I couldn't help but also just highlight the risk for chronic lung disease for these patients as well, just because we're in pulmonary grand rounds. Further, these authors looked at adjusted risk for these outcomes, and as you might expect, are seeing a 50 to 60% increased likelihood of developing impairments for overall just, activities of daily living and pulmonary conditions when other factors are adjusted for as well. I feel as though the talk wouldn't be complete with some recognition of the toll that the COVID pandemic had on patients who were incarcerated. And if you're not familiar, it was pretty devastating for those who were in detention. The initial estimates were for COVID crude rates of 3,200 for those who were incarcerated per 100,000, compared with about 500 or 600 for those who were in the general population. And similar to what we saw for overall incarceration rates with that 45-degree angle, you see in the dark bar or the dark line, the COVID positive rates for patients who were behind bars compared with the general US population represented in the orange. And so these differences were representing at least a 5.5-fold higher risk of COVID positivity and 3 times higher mortality relative to sex and age-matched SMR. These trends continued for the first year and a half or so of the COVID pandemic. And I haven't seen additional data to tell us how it landed in later years, but clearly was a burden that was borne more heavily for patients who were incarcerated compared to the general population. And so this leaves our patients with a number of factors that are working against them and having to both serve their time behind bars, but also have us serve them as our patients. And it can become really untenable and difficult for us to identify how best to deliver the care that we would for our patients in general, without carrying with us that stigma and ways that we're causing more harms for patients. So I thought we would go through some of the obvious low-hanging fruits for potential threats for patient-centered care. But this also brings me to a bit of the why that got my group together for the Scopes and Shields. And I'll warn you that the story I'll share is really upsetting, but also I think important to not forget and to have to tell. And so this is for the memory of Elijah McLean, who was a 23-year-old man walking home from a convenience store. He had his nose and mouth covered and was deemed to be a threat by a passing motorist. He was apprehended by the police, and they were trying to restrain him and putting him in a chokehold while he's begging and pleading, saying he's an introvert, he's just different, and he didn't understand why he was being attacked, and he's pleading for help. At which time he received 500 milligrams of ketamine for excited delirium. He was left unsupervised and essentially was found to have anoxic brain injury in the medical ICU where he was cared for. He had a family who continued to be really selfless through all of this devastating news and wished to pursue organ donation for him. However, the bedside care that was delivered to him was marred by very steady law enforcement presence, as well as sort of free sharing of PHI, or a perception that it was being used more freely than it should have been. And the family potentially being treated like suspects themselves instead of a grieving family that any of us would want to be able to support during such a difficult time. And further, what we were catching word of from providers was just the huge moral injury that this led to and the uncertainty for how to navigate such a situation. And some clarifications: Elijah McLean hadn't broken any laws. I definitely respect the police and the job that they do, but racial and ethnic disparities that deeply rooted and influence how somebody becomes justice involved and the force with which they're met with. And I think we need to be honest about that. There are many things we can do at the bedside, though, to make sure that we're using the tools we're already familiar with to promote patient and family-centered care, assuring that we're having open conversations about sort of a least required restrictions and restraints for patients, and checking in with law enforcement to see if there are ways that we can kind of have some guardrails over expectations and restrictions for their role during the care of patients that we provide. Because we're definitely not getting it right. There's evidence to suggest that we are less engaged for providing care to patients who are also incarcerated. There's ample opportunity for privacy violations that we'll walk through. The environment is a nightmare for anybody in terms of if you care about sleep hygiene, with no control over light and noise that's going to be taking place in the hospital room. There's often impaired autonomy. There are fewer interventions potentially being delivered, and excess use of shackles or handcuffs, as well as poor care transitions from the hospital back to the prison for patients who are requiring heading back there. So I want to just help us think about the usual care for patients when they come into the hospital and into the ICU is to minimize restraint use. However, for people who are shackled, it tends to be applied routinely and without necessarily a lot of questioning if it's necessary. And remember, this could also be somebody who wasn't necessarily charged with a crime. Privacy is also something I think we're really protective of on behalf of our patients. We make sure that we don't have discussions in the elevators. We make sure that we don't have, non-surrogate decision makers and key stakeholders around to discuss the case for somebody or their care. Yet not infrequently, for people who are justice involved, there might be a corrections officer who's parked right outside their room or even in the room while important health information is being shared. There are also some variations in how decision-making may be approached, where we deviate from looking for the patient to call their own shots or their closest loved one to be their surrogate decision maker. Whereas for those who are justice involved, we may be looking for permission from prison personnel and corrections officers in order to know how to proceed. There are additional ethical themes, no doubt, but for the purposes of the talk, I'm just going to focus on these first three. If you're not aware of what shackles look like and what their harms are, this report from the JGIM is something that I think should be really, really sobering for us to see. These are pictures from someone's wrist who had had a shackle applied, and after just 2 days had these really deep skin ulcers that developed from the handcuffs that were in place when they had sought mental health attention, were identified as having a warrant out for their arrest, and shackled to their bed as a result of that. There are a number of misconceptions for the use of shackles during acute care in the hospital and in the ICU. There's a sense that they don't cause harm, but also we're just going to be a little less empathetic probably for somebody who is restrained to a bed with a metal shackle compared with general population. There's also a sense that perhaps we just do this automatically. We just know that it looks wrong and we're going to always ask for the shackles to be removed. But there's nothing to say that we are actually doing that in surveys of healthcare providers in acute care. We're also, though, not sure, are we allowed to? Like, do we talk to corrections officers? Can we ask about least restrictive ways of taking care of our patients? And I think we just assume that we're not allowed to really ask such things, when in fact, that's not the case. It's still our house, and we can certainly ask for these types of changes to care as long as it's medically necessary and sort of negotiated as a team. There's additional concerns that may be raised that if something goes wrong, that we're going to be on the hook if somebody, is able to break out of the hospital, and that it's due to us not providing enough security, when in fact our job is to be healthcare providers without bias for the patient's carceral status. And the corrections officer who's available there is charged with helping with security as indicated. There's also a sense that this will give us some degree of safety, but this assumes that that we're taking care of are violent offenders, where in fact the sort of national and local data indicates that the minority of patients who are incarcerated are there for violent injuries or for violent crimes. As well, there's a sense that removing shackles might reduce our security, and there's not data to support that either. Finally, and maybe most harshly, some of us think that, well, I mean, I didn't break the law and I get to be free. This person did something they weren't supposed to do, and so this is part of the deal for having broken the laws, that they have to have the shackles applied. But in fact, a couple of reminders. One is that those coming in from a jail haven't necessarily been charged for the crime, as we mentioned earlier, and is evident for a patient like Elijah McLean. But also when somebody is tried, they're living a lot of their day-to-day without shackles on. They're meeting with lawyers, they're meeting with corrections guards, they're carrying on in the prison without a lot of physical restraint. And so it seems odd that we allow so easily shackles to be a part of the clinical care that we're delivering in the hospital. In additional survey responses from providers, there is additional sense of, sort of a higher bar to try to get ourselves moving to provide the care we otherwise would when somebody has a shackle in place. We probably have some negative perceptions of what, of our own safety as well as just sort of judgments about the patient. And that overlooks all of the sort of systemic biases that go into incarceration in total and are ways that we're kind of not doing as best we can for our patients. As well, we know that we don't ask for removal as much as we should. Moving on to privacy and dignity. The rules we function under as healthcare providers for protecting privacy are vastly different from that of people who are incarcerated. But remember that we're here when someone's coming to the hospital for care. Our job is to be their healers, not to be an extension of law enforcement, and that we can continue to provide care, protecting dignity and or promoting dignity and protecting privacy as we would any other patient. Those rights to privacy are protected in our states, and sometimes it can be as easy as a conversation with law enforcement just to ask about how we can assure that we can have these conversations while giving the patient the space they need to be able to process some serious health news. Just for some framework for what's written in the Connecticut laws, there are some really small font that I don't intend anybody to read line by line, but just indicates the sort of overall provisions that that the state has for protecting privacy for patients. And there might be exceptions here and there, but it really should be with some sort of pathway where the person who's incarcerated is protected and that we're not freely sharing or disclosing personal health information. We have similar privacy policies for our health system, of course. So then our third theme for ethical challenges are around medical decision-making. And for this, we don't have a lot of insight, but are fortunate to have people like Erin DiMartino and her group that have started to try to pull the curtains back to take a look and see what we're doing for medical decision-making. They identified patients who were incarcerated and incapacitated between 1999 and 2019, and were able to find 34 patients with 43 admissions. The average age was around 56. Race was incompletely characterized for the patients that were included here, and 29% of patients had an advance directive that was evident prior to coming into the hospital. The overall medical conditions, I think, seem pretty familiar to what we would see for this sort of cross-sectional single site look at incarcerated people with change in mental status, respiratory failure, sepsis, GI conditions. Of interest is that 28% of people came in without a baseline ability to make their own decisions. Another 30% had a new change in their ability to make medical decisions, but it resolved prior to the ending of their hospitalization. And 42 had a new change in capacity that persisted throughout. About 60% of patients returned back to prison, or of admissions returned back to prison, and 40% were discharged to hospice or died. And so the team did a deeper dive at who was making these medical decisions, and encouragingly, the majority of the times it's going to be families who are involved. And so these data are represented in figure 2 to the left, where you see, and again, these are modest numbers for 34 patients, 43 admissions. So family is certainly there, but I'll also call our attention to the figure that's on the right, that's labeled figure 3 from the paper, where we see that prison employees are involved in medical decision-making for 22 of the 43 admissions. This isn't some nefarious plan that was undertaken by corrections officers. It's really about trying to help unrepresented patients have some decisions made, emergency medical decisions that are occurring, but also things like co-consent and presence in family meetings was identified in the chart review for medical decision-making for patients who were incarcerated. They were further able to glean some themes from the way that this was written about in the electronic health record, where the team was expressing uncertainty over how to assure medical decision-making was taking place according to what the expectations were because of the person's carceral status. There was also uncertainty as to whether there had to be a check-in with prison in terms of if the patient can make their own medical decisions. Further, there was often a sense of deference and sort of, again, this sort of checking in with the corrections officers or the warden to determine if they can make these decisions for changing code status, for example, even if there was a family member there, just to make sure that there wasn't some sort of special circumstance where that's going to be denied for the assigned surrogate decision maker. And there seemed to be evidence of breach of privacy with excess sharing of health information with corrections officers who otherwise shouldn't really be privy to or weighing in on the course of the treatment for the patients included. So we have a lot of problems to tackle here, but of course, with problems, part of the best thing we can do is name them and start to identify strategies to do better. And that's what I hope to close with for us here today. But know that we are really shooting in the dark for how to proceed. This is work that one of Erin's mentees out at Mayo has conducted, looking at professional societies who are members in the AMA House of Delegates. And Nick was able to find 14% of medical societies had any sort of indication of thinking about incarcerated population and special needs that we should potentially consider. The themes included sort of behavioral and medical conditions specific to the specialty, as well as things related to socioeconomic factors, health disparities, and the right to health care. There were special content areas for people who were older, as well as the youth, as well as queer community. But, really not a lot for us to sink our teeth into to try to understand what our responsibilities are for caring for patients who are incarcerated. We're so lucky to be where we are and to have some world-renowned leaders in thinking about justice-involved individuals and advocacy and policy. If you're not familiar, Emily Wang is director of the Seach Center here, which is a Center for Health and Justice that has really done groundbreaking work in characterizing and mitigating the harms of mass incarceration on the US. There are additional folks who have joined in the last few years. Carmen Black is from the Department of Psychiatry, and she, with Lisa Puglisi, had an AAMC Educational Award that's called the DEPART Initiative for Detained Patients Advocacy and Rights Through Treatment, which has also really prioritized community engagement. So finding patients with incarceration history to join the conversations so we can identify where we continue to fall short and how we can come together as teams to improve care for patients. As well as Shioko has always been very receptive to these discussions and has also helped us to liaise with additional leaders throughout the health system to think about ways to improve acute care for incarcerated patients. Beyond Yale, there's also people like Bree Williams who directs the Arch Center at UCSF, the Stop Shackling Patients Group out of BU, the HELIP, or Health Equity and Access to Law Enforcement Involved Patients, and Families Against Mandatory Minimums are additional groups, but not by any means an exhaustive list of areas we can go to find partners. And so for our part in pulmonary critical care, I got to know about this problem and think about it a little more critically through my role at ATS when I was chairing the Ethics and Conflict of Interest Committee. And again, what we first needed to do is just name the problem and come up with some of the ways that we just shouldn't necessarily be complicit in allowing these unfair treatments to continue. But we needed a language around it. We needed to find some ways to find a path to do better. So we started with a publication, a perspectives piece a few years ago, but didn't feel like that was enough for us and wanted to keep meeting more people. We were really inspired by the stories we were hearing. And we're able to include Erin in our group, as well as Wes Ely, Bruce Adelson, who is a lawyer at Georgetown, and David Chulgin, who actually had been a former ethics chair for the ATS, but is also an MD and a JD. And we formed this group called Scopes and Shields, which aims to empower healthcare workers to protect and advocate for patients who are in law enforcement custody or involved in the criminal legal system. Our mission is to advocate for medical practices that prioritize dignity for incarcerated patients, with a vision towards alleviating suffering regardless of somebody's carceral status. And so this is helping us at least have a little bit of something to build on for resources to help providers and address some of the uncertainty and moral injury that it sounds like many of us are facing, but not necessarily having the words or place to discuss those challenges. So we want to move on to solutions, and we talked about the excess use of shackles. And I can't say enough about how impressed we are with the work that's been done by the Stop Shackling Patients group. These are like second and third year med students at BU who just continued to poke and try to make sure that they had policies in place to protect their patients, and really just wouldn't rest until the facility would hear what they were doing and start to change their policies, which they've successfully done, has been adopted by some of the Harvard programs and then further adopted by the state of Massachusetts as well, in order to reduce the use of shackles for patients who are incarcerated. But this also doesn't necessarily need to have a complicated flow diagram. It was really helpful to have some references to start to think about what this looks like, to get a little bit of a muscle memory for how to have these conversations with our care teams. But it also can be as simple as having a patient before you who's shackled to their bed and just asking for the shackles to come off if the corrections officer is in agreement. This is a photo that Wes took with permission for a patient he was taking care of, who was intubated and sedated in the ICU and was so smoothly and easily able to just have this removed. And it just changed the entire mood of the room and the way that care was provided for this patient. So we've identified additional sort of low-hanging fruits and simple ways to just develop a language around advocacy at the bedside for patients who are justice involved, for some of those key themes around privacy, PHI protections, as well as assuring that we're identifying surrogates and not empowering law enforcement officials to be the ones who are making medical decisions, because I'm sure they don't want to be in that position either. And so I think just having this be part of our usual intake for patients who are justice involved could go a long way. The Scopes and Shields group also has other themes and decision-making tools, again, aiming to be a resource for clinicians and looking at different settings from inpatient to outpatient. We're looking to grow a little bit in areas I don't really have much authority to speak about in terms of obstetrics and pediatrics. And again, we just try to have a fairly simple, like, what is the problem that people are coming to us with and how best to start to navigate it? What sort of strategies do we feel like are going to be helpful in the moment for somebody? We also had an opportunity to contribute an ICU one-pager for the care of criminal justice involved patients, and aim to continue to update this as is relevant and as is needed, so that it can be that 2 a.m. resource for the hospitalist or the intensivist, resident, whoever is all of a sudden seeing something that just doesn't feel right and isn't sure how to reference what the right path forward would be. We've been pretty excited for some of the partnerships we've had through ATS, where we were able to contribute to an AMA resolution to develop best practices for acute care for patients who are justice involved. We continue to look for partnerships and collaborations and learn from a lot of other experts in the fields. We, again, are trying to just develop templates so that we can make this easy for people to replicate in their own institutions to assure that this patient-centered care isn't something that's sacrificed for patients who are justice involved. While along the way also finding opportunities for scholarship through grants and papers and just opportunities to do things like have grand rounds in pulmonary. So we're just about done with the discussion. I thought it might be nice to hear a little bit about how some of our patient cases ended. And I'll tell you that the young man who I told you about with lymphoma continued to be in remission. And I actually got to know him through the work that he's doing with the DEPART program and Carmen Black's initiative to educate our generation and next generation of healthcare providers for what we don't realize that we're doing that sort of is transmitting more of unconscious bias and unfair treatments potentially for people who are justice involved. For those who had followed the case in Elijah McClain's unnecessary death, there were convictions against the paramedics and one of the police officers as well. And those just came out in the last few months, though I'm sure it never will actually fill the void of his loss for his family. So in conclusion, mass incarceration augments racial and ethnic disparities. This is associated with greater comorbidities and frailty and geriatric syndromes for patients, so that we're often going to be seeing patients coming in with those conditions decompensated. And there may be some habits that we let ourselves fall into, or some lack of questioning that we're doing that prevents us from delivering more patient-centered care for justice-involved patients. One of the first things we can do is just stop using words that are stigmatizing, such as prisoner and inmate. But then embracing our position of professional privilege to meet patients' unmet needs, to advocate for dignity and compassion for justice-involved patients in the acute care setting. So I'll thank you and take any questions.
Thank you, Kathleen, for that wonderful talk. We're now open for questions.
Thank you. That really was amazing. Thank you, Kathleen. So you may have gotten into this a little bit, but I'm not sure. So a couple of years ago, or a few years ago, when I was on the ethics committee here, there was a case that came to our attention where a patient was known to have done something really awful. And members of the care team, because they knew what this person had done, felt very uncomfortable and unwilling to take care of this patient, to the point where it was almost like compounding the punishment, like saying like, he doesn't deserve this, et cetera. But what we were called upon to do is to try to support the healthcare team who were having trouble. Like, it was a sex offender. And so the question is, have you thought about that, or is there some sort of guidelines that you can give us when members of the care team are feeling squeamish or uncomfortable about providing medical care to people like that?
Yeah, I'm glad that you brought that up, Mark. And that is something that we addressed, I believe, in our paper, and certainly other thought leaders in the field have considered that, frankly, we need to go forward without knowing that it's not relevant to the patient being treated in front of us. And so it's only going to muddy the waters and make us less the people we need to be. And so we very much discourage any sort of inquiry or Googling of what the person's criminal history is, what they were charged with. And I think that's really the most ethically sound approach to take. I imagine there are some individuals who may have had higher profile cases, and it can be hard not to know what they have done. I served on a jury for one in particular that would be really challenging to have to take care of. Anyway, set that aside. Sharing too much. But I think as much as we can separate ourselves from knowing about those circumstances, especially for what we understand about incarceration in general, just being a very disparate experience for members of the US population.
Thank you so much. I feel like I've been interested in this topic, and I still feel like I learned from your talk, which is wonderful, and I think it shared wider this section. My question was about the aging population within the justice system, and whether we know anything about why that is. Is that is it less death penalties and therefore more life sentences that's leading to a growth population, or more sentencing of life terms than we had decades ago, or like less people dying while they're serving their life sentence and therefore living longer? Like, what is the reason for why the population is so changing?
Yeah, I think that's also a really important observation for how that happened. I am not an authority in unpacking this, but the question that Isabel was posing is, why do we have an aging prison population? What are the mechanisms that sort of got us there? I think in part, this is the legacy of the war on drugs and the really heavy sentences that were handed down for relatively minor drug infractions in the 80s and 90s. And that's been really hard to undo. I think that's one aspect of it. You know, there are probably a lot more complexities to it, but it's beyond my level of expertise to say further.
I don't know there it is. That was one of my questions. So I'll ask the question from the chat here. Dr. Gulati wants to know some of the challenges occur in outpatient ambulatory setting and communicating with the patient's care team to execute a treatment plan. Any thoughts or advice?
Yeah, so I also wanted to weave in, and hadn't, but maybe now I'll make a plug for thinking about the ambulatory pulmonary care. I can't imagine caring for someone with ILD in particular, and as Murdu might be facing, but it's really in fits and starts in terms of access to the healthcare team in the prison versus outside of the prison. And that's where people like Lisa Puglisi are really just trailblazing to improve that transition from detention-based healthcare to community-based healthcare. But one area that I'm pretty eager to see results from is what Ethan Bernstein is doing for UConn to look at lung cancer screening for patients who are justice involved, and that choppiness of the care that they're going to get when they come see a specialist versus when they're detained. And perhaps they finish serving their sentence and are back in the community, but don't necessarily have healthcare coverage that will be able to afford them things like lung cancer screening or antifibrotic medications, I think is a real challenge, and something that I think we have to develop some sort of guidelines for how best to assure this type of therapy is provided. I saw Carly and Luke also had some questions.
Thanks, Kathleen. Fantastic. I'm just curious what determines in Connecticut where patients are admitted and cared for. I think I've seen in my experiences, early in my training, caring for prisoners in a hospital that's not used to caring for them versus later on caring for them in a place that was sort of a destination for prisoners, and how or people who are incarcerated, and how just how different the norms of treatment were. And is that an avenue to kind of improve the quality of care and the treatment that individuals get by having them go to sort of centers of excellence or centers that have been recognized to adhere to some of the best practices that you described?
Yeah, I think that's a great suggestion, Luke, and seems like something we could do at least at a regional level in Connecticut and probably across the country as a good model. But I have a feeling the decisions are made just based on geography. I don't know with certainty that that's the case. I'll say that our local law legal representatives are invested in helping us with this through the Families Against Mass Mass Detentions, the FAM group. You can request for our lawmakers to go and visit a prison, and they have been really responsive, the state senators and local legislators, to say, like, what sort of problems do you want me to bring up? And I mean, I encourage folks to do the same, to maybe also think about developing centers of excellence for acute care for incarcerated patients, so that it isn't this sort of idiosyncratic care that's delivered for folks that might be a little less familiar to the type of care needed. I think Carly had.
Wonderful talk, Kathleen. I was just wondering if your Scopes and Shields team and or other organizations nationwide are partnering with patient organizations to foster equity for people who are in the legal system.
Yeah, there are a number of patient-driven groups that I would want to do a kind of discipline search to find, but I'll say that the work that Carmen Black has done is very much informed by community engagement from Women Against Mass Incarceration, or WAMI, which is led by women who have experienced incarceration and are moving to, raise consciousness and improve visibility and opportunities for returning to a life in the U.S. that's recognizable to the rest of us. So, but yeah, I think certainly engagement with people who have been incarcerated is going to be critical to improving these problems.
Okay, so Much for the talk. I think it's so important. And I have a particular question concerning this in terms of the other side. So a lot of those patients have jail, facility healthcare where they first of all see a doctor there, medical director, and a lot of it is handled there before they even start coming out. And from me being in the DC area and taking care of some of these patients, I realized that there were particular difficulties keeping to appointments and knowing how important some of those referrals are, knowing the reason why the patient is even coming in the first place. There's so many problems, especially in the outpatient. So my thought is there is a major part of the problem originating from the other side in terms of their not knowing or maybe the policies that they have. And they do have health workers in there, nurses, doctors, even though it's a smaller health care force. But are you involved in reaching out to the other side, or is there any movement towards trying to fix some of that? Because I think it really impacts how and when they get to us, especially in the ICU. We recently had one over here where, he was distressed for a long time, and it took some clinical deterioration for someone to kind of change their approach to
Sure.
how he was treated. Yeah.
Sure. May I just thank you for that point also, and really getting at some of the root cause issues for health. I just want to make sure I clarify. You're asking for the healthcare that's delivered in the jails and prisons itself, and I intentionally sort of glossed over that. That's really going to be probably its own workshop to try to unpack. But the sort of short answer is that there isn't necessarily, while there's an expectation that healthcare is going to be addressed for people who are incarcerated, what that looks like, how it's regulated, how the quality of care is guaranteed or monitored is not something that's been uniformly prioritized across different states and across different prisons and jails. So it's certainly an area where advocacy could be another place that we could establish some baseline expectations for what that care looks like. But thank you for that.
Kathleen, there's a question from Dr. Mario Perez who wants to know, do you think compassionate release is underused and should we advocate more for it?
Oh, Mario, I love hearing from you and I love your question. So yes, is the short answer. Compassionate release, if you're not familiar, is something that programs such as FAM allow you to enter into to be a sort of reviewer for patients who have medical problems, serious medical problems, and are incarcerated. And we can offer our services as healthcare providers to review the cases that patients are living with, the conditions that they're living with, to make a case for them to have their sentence sort of lessened or time served be completed so that they can live with life-limiting conditions, geriatric conditions, dementia, all the above, at a place that is where they're with their family members. So that's what a compassionate release program is. And there are ways that we can get involved if that's something we'd like to do as individual providers, thinking about our expertise in sleep, in pulmonary medicine, and in critical care medicine. That's certainly underutilized, but something that we can do and make a difference, I think, in no time. So.
One more question, Kathleen.
Sure.
From Steph Capucci. We have been told on multiple occasions when patients in carceral care are brought to the neuro ICU that we cannot update their families, healthcare providers with routine updates. Does this have robust legal backing? Very few of our patients have capacity to given their acute brain injury. It then becomes very difficult for the healthcare provider or to make healthcare decisions if they haven't been included in early conversations.
Yeah, I think, we would probably want to verify why somebody isn't otherwise able to have the usual decision-making, medical decision-making being done by their designated surrogate decision maker. So I would be curious to know the institution, and I'm sorry if that's us and I don't know it. And, think we could speak though with risk management and our hospital attorneys to make sure where's that disconnect for unit-based practice that seems to be going out of line with what we otherwise would understand to be a very basic sort of right for a patient to have a family member who is invested, knows about them, cares about them, be their dedicated and designated surrogate decision maker in such circumstances. So, all right.
Thank you, everyone, for coming to today's State Chest, and I want to thank Dr. Akgün.
Thanks, everybody.